Dear student, today we will discuss an important topic about pharyngeal diseases. My name is Dr. Ahmed El-Hamshari. I am an otolaryngology head and neck surgery lecturer in Tanta University. So first of all, we will try to outline the lecture intended learning objectives. So by the end of this lecture, every one of you should be able to understand the main features of the clinical presentations of Group A beta hemolytic streptococcal pharyngotonsillitis and know their main treatment lines. Also, you should be able to recognize the pathophysiology of peritonsillar abscess and their treatment lines. So let's start with the group A beta hemolytic streptococcal bacterial pharyngotonsillitis. So first of all, this is one of the most common cause of bacterial pharyngitis. It could affect any age, but however, it's more common in children. The causative organism is group A beta hemolytic streptococci, while mode of infection is droplet infection. Regarding the clinical picture, normally a patient with group A beta hemolytic streptococcal bacterial pharyngotonsillitis present with three main features. The most characteristic features are the high-grade fever, which are usually up to 39 to 40 degrees centigrade, associated with sore throat and odynophagia. And odynophagia means painful swallowing. Many times, those patients develop headache, anorexia, malaise, and earaches. While in severe cases, there will be some rigors and marked toxemia. Regarding the clinical signs, normally this patient show flushing with hot, dry skin, fetid breath, which means bad mouth odor, and high fever with tachycardia. While locally, there will be bilateral red swollen tonsils, which may be spotted or covered with grayish-white exudate or false membrane, which this patient usually having enlarged tender jugular-digastric or cervical lymph nodes. We don't normally investigate patients with group A beta hemolytic streptococcal infection, but we start them straight away on empirical antibiotic treatment. But we might need a throat culture or rapid antigen detection test to confirm the diagnosis in severe or persistent symptoms despite the adequate empirical antibiotic treatment. The other investigations that you might need, which is monospot test and complete blood count to exclude other causes of sore throat, like agranulocytosis or infectious mononucleosis. The complications that might develop in group A beta hemolytic streptococcal bacterial pharyngotonsillitis could be widely divided into suppurative complication and non-suppurative complication. Suppurative complication includes peritonsillar abscess if the infection inside the tonsillar crypts ruptured through the tonsillar capsule in the peritonsillar space, then the patient will develop the peritonsillar abscess, or it might rupture through the sphiroconstrictor muscle into the parapharyngeal space, so the patient will develop parapharyngeal abscess, or it might spread through the lymphatics to the lymph node funnel in the retropharyngeal space, and if this ruptures with the pus accumulation in retropharyngeal space, the patient will develop retropharyngeal abscess. Regarding the non-suppurative complications, the most important one and the most common one is rheumatic fever. This typically develop after a latent period of 1 to 4 weeks. And the next most common is post-streptococcal reactive arthritis and post-streptococcal glomerulonephritis. Scarlet fever might develop as a non-suppurative complication. And the last one is pediatric autoimmune neuropsychiatric disorder associated with a streptococcal infection. So the abbreviation is PANDAS. Regarding the treatment of group A beta hemolytic streptococcal bacterial pharyngotonsillitis, all patient needs bed rest, soft diet, and fluid and huge amount of fluids. Most of them needs antibiotics to control their fever, and all of them needs antibiotic for at least 10 days. Penicillin and amoxicillin are the first choice. while azithromycin or clarithromycin might be used in penicillin allergic patient. Most of them benefit from a single dose of oral or intramuscular corticosteroids, especially in adults. All of them needs antiseptic mouthwash. The second topic in today's lecture is the peritonsillar abscess or quinsy. So the definition of peritonsillar abscess or quinsy is a collection of pus in the peritonsillar space between the tonsillar capsule and the superior constrictor muscles. The etiology is that peritonsillar abscess usually complicates acute tonsillitis when suppuration involves the crypts of the supratonsillar fossa and are closely related to the capsule of the tonsil. Causative organism, usually two organisms are incriminated in peritonsillar abscess, which are group A beta hemolytic streptococcal infection and anaerobic infection. Clinical picture. Normally, this patient, the problem start as a preceding acute tonsillitis. Then the patient starts to develop general symptoms, which are fever, anorexia, headache, and malaise. Locally, the patient normally complains of a progressive sore throat. Pain is usually unilateral and throbbing. I may be referred to the ipsilateral ear. And the second common symptoms is dysphagia and odynophagia. So dysphagia is difficult swallowing, while odynophagia is painful swallowing. This causes accumulation of saliva, and the patient is not being able to swallow his own saliva, which will result in drowning of the saliva, which is very characteristic to the peritonsillar abscess. Trismus is one of the most common symptoms the patient presents with, which are normally due to reflex spasm of the trigoid muscles, while the last symptom is hot potato voice, which are normally due to oropharyngeal swelling and edema. Examining this patient, so generally they normally present with proportional fever and with tachycardia and irritability, which is quite characteristic in bacterial infection, while locally, if you look at the pictures in the slide, you could see there is unilateral swelling of the soft palate, above and lateral the tonsils, with medial displacement and limited mobility of the uvula, and downward and medial displacement of the tonsil. In the same patient, we normally observe there is limited mouth opening, which is virtually pathognomonic in peritonsillar abscess. Also, examining the neck, it will reveal enlarged tender jugular-digastric lymph nodes. Differential diagnosis of peritonsillar abscess. All tumors of the tonsils are in a differential diagnosis for peritonsillar abscess because they normally present with the same symptoms and signs. Aneurysm, which may be internal carotid artery aneurysm, and in such cases, you might get some blood if you do a diagnostic aspiration of the peritonsillar abscess or peritonsillar swelling. Complication of peritonsillar abscess includes rupture of the abscess leading to inhalation pneumonia, spread of infection through the superior constrictor muscles, which may lead to parapharyngeal abscess, spread of the infection to the mediastinum through the parapharyngeal space, which might lead to mediastinitis, which is a fatal complication. Treatment could be broadly divided into medical treatment and surgical treatment. So for the medical treatment, is normally indicated in a stage of peritonsillar cellulitis, so before the pus accumulation. It normally consists of a parenteral antibiotic, which means intravenous or intramuscular antibiotics, adequate hydration, and analgesic. The second line of treatment is surgical treatment, which is indicated in the stage of peritonsillar abscess, which means after the pus accumulation or formation. You could manage this patient surgically through two different lines of treatment. So drainage of the abscess, which is required if pus accumulate, either under local or general anesthesia by needle aspiration or incision and drainage with quinsy knife. Then all of this patient, it will eventually need a tonsillectomy, which is better or preferably to be delayed for 1 month after resolution of the attack to prevent the abscess recurrence. You could clearly see this is our references for our presentation, and you. Good luck, and I would thank you. I would happily answer any of your questions.